Hello and welcome to the webinar. We're going to give folks just another minute or two to figure out technology and to sign in. So sit tight and we'll be right back with you. All right, let's get started. Hello again. Welcome to Managed Care Contracting, the Plan Perspective. My name is Dan Ferris. I'm the Assistant Director here at the McSilver Institute of Poverty Policy and Research, and a proud member of the MCJack team. We're so glad and lucky today to be joined by two experts in managed care contracting, Harold Iselin and Whitney Phelps from Greenberg Traurig LLP. And they'll be sharing their experience and expertise and specifically what plans they're going to be looking for and expecting from providers. So before we dive in, just a few words about managed care technical assistance and the programming we'll be offering in the coming months and year. So MCJack is a training, consultation, and educational resource center that's offering resources to all mental health and substance use disorder providers across New York State. The goal for MCJack is to provide training and intensive support on quality improvement strategies, including business, organizational, and clinical practices. Our goal is to prepare and assist providers with the transition to Medicaid managed care, as many of you could probably surmise from the programming we've been offering and the name of the Technical Assistance Center. So we're working closely with OASAS and OMH and other government and provider partners to provide foundational information. This is through in-person forums, webinars like what we're offering today, and as we get a little further along into 2015, in addition to some of this larger based format information sharing, we'll be doing more intensive learning community and group consultation work. So stay tuned for that as it comes through. MCJack is made up of a robust collaboration of partners, both from an academic standpoint on the substance use side, as well as from a service providers. So that includes the McSilver Institute, CCSI, the Institute for Community Living, NIAPRIS, who we just co-sponsored a conference with in Saratoga last week, who I would imagine some of the folks on this webinar were able to join us for, And then we're pleased to welcome Casa Colombia to the team to specifically offer their experience and expertise around substance use providers. And then just really quickly, we have a few suggestions for the folks who are taking the time to join us for all of this technical assistance and programming on what you can be doing as we approach the transition to Medicaid managed care to make the most of these supports and to help your agency and organization be prepared. So the first is to designate a project team, including agency leadership. There's a readiness assessment that was distributed earlier in the fall, and there was an initial deadline for submission, but just so folks know, we are accepting those on a rolling basis, and we'll be sending feedback and benchmarking back to providers on a rolling basis. And then I believe we have a quick polling question that might pop up as we're talking through this slide. But we're in the middle of our contracting unit. This is following a 12 kickoff that we did in partnership with the state around New York. Over 1,500 people came to those in-person events, and another 600 joined for a live stream of the Albany live stream. So building off of that unit and for contracting and all of the training units moving forward, the model will basically stay the same, where we'll do overview events to kick things off, and then I'll dive into some more web-based content as we go. So for contracting, we've held and are holding 5 in-person events. We were in Rochester and Long Island before Thanksgiving. Last week, despite a little bit of inclement weather here in the city in Albany, we had really successful units. And then it's actually we're excited to announce that the 5th and final in-person contracting unit in person, which are being presented by Adam Falcone, will be held in New York City on January 13th in the morning, and we'll be sending out a formal announcement about that later today. So if you aren't receiving our emails for whatever reason it is and you've just stumbled across this webinar, you can go to mcjack.org now and sign up to receive that exciting announcement. And then in terms of the web-based content we're doing for contracting, today's webinar with Harold and Whitney, which we'll be jumping into shortly, we're also looking to do a provider and policy perspective. So today is the plan perspective, and then we follow up with that in January. And then Adam will be rejoining us again in later January 2015 to talk us through a summary of the information that he used to synthesize the longer presentation, and also answer those nagging questions that have popped up since since you've joined. And then later in 2015, we'll be rolling through with finance and billing, utilization management, measuring and improving outcomes, and more. And it looks like from the poll results that it's pretty split actually with folks who did and did not attend one of the in-person events so far. So 71 yes and 75 no, which is great. That's half of the people on today were able to join us. And hopefully we'll get at least some of the 75 who didn't to come and see us in January. So that's it from our end. As always, if you have any questions whatsoever about the technical assistance that's being offered or feedback in real time, please shoot us a quick email at mcjack.info@nyu.edu. We have more information and access and archives of past webinars and trainings available at our website. And in terms of the webinar today, we'll be holding a question and answer session following the presentation. If you see in the top right corner, there's a little chat icon and a box that'll pop up that'll allow you to send questions into the presenters. So they'll be going through this towards the end of the presentation. And with that, it is my pleasure to turn this over to Harold and Whitney.
Thanks, Dan, and thanks everyone for attending. This is Harold Islin, and I'm here today with Whitney Phelps.
Good afternoon, everyone.
And we appreciate very much the number of people who are joining us today. Just as some background, our law firm, Greenberg Traurig, represents the New York Health Plan Association, and we also have done quite a bit of contracting on behalf of many health plans. So what we want to try to do today is walk you through the key provisions of a managed care contract, but we not only want to explain what the provisions do, but why health plans care about the provisions, some of the issues you should be thinking about with each provision. We don't want to do a law school class today. What we'd like to do is give you some practical and business-focused advice as you begin. Some of you we know have contracts, but for many of you as you begin the process of thinking about managed care contracting, we hope that you'll come away today with some useful lessons. So we've got a slide up there on different types of contracts, but let me start with an observation about managed care. Unlike fee-for-service, managed care is a system from a regulatory perspective that is built on contracts. There is the contract that runs from the health department or CMS to the health plan. There is the contract that runs from the health plan to a provider, to a management service company, sometimes to an IPA. And where you have an IPA, and we're going to talk about IPAs in a little bit, you've got the contract that then runs from the IPA down to the individual provider. And each of these levels of contracts is heavily regulated. The contract between New York State and health plans for Medicaid managed care is hundreds and hundreds of pages long. The contracts that run between health plans and IPAs can be 30, 40 pages with a significant amount of regulatory oversight. And the contract between a health plan and a provider or a management service company is also regulated. So just as you think about the entire delivery system, you should think that at each stage, these contracts are the building blocks for the services that are going to be provided, as well as for the regulatory expectations, both of health plans and of providers. So the first slide, we've just identified the three key types of contracts we're going to be talking about today. And now let's just give a quick overview of each, and then we're going to go in to a much more detailed level. So the main contract that I'm sure you're all concerned about is the provider contract, which is the contract that runs between the health plan and the provider, or it could run between an IPA and a provider. The provider contract at its most basic is the contract for the services that are going to be provided. Those are typically health services or behavioral health services, but there are other things as well, and certainly as we're talking about behavioral health and HARP, you all know that there are a range of services built into the HARP program that go beyond just services that a licensed provider might provide, because again, there are some non-traditional services that are part of the HARP benefit package. The very important point that you need to think about here is not every service is a covered service. Whether you're a hospital, a behavioral health provider, you know, a doctor, not every service that you provide is necessarily a covered service. So you say to yourself, gee, how do I know what's a covered service? Well, as we're going to tell you, you're going to have to understand that, you're going to need to go to the contract that runs between the Department of Health and the health plan, because there are a series of benefits. And those are the services that are part of the Medicaid managed care program, whether it's the main program, whether it's HARP. There are a series of services. It's very broad, and certainly the HARP services are a significant amount of behavioral health services that are being added to the benefit package, but it's still not everything. And so when you think about the services that you want to see included in your provider contract, it will be most of what you do. It may be almost everything you do if you're a provider, but it may not be every single thing. And just a good example ripped from the headlines today, for those who read the paper, the state has just added to the Medicaid managed care program a specific requirement that gender change operations are now going to be part of the Medicaid managed care program. but a week ago they were not part of it. So again, it's very important as you think about this right at the outset to think, what are the services that I'm providing? So let's talk a little bit about IPA contracts. I think that there's some interest on the part of many providers about using IPAs as a contracting mechanism. And if you look at the chart, that gives you a little good, good idea of just how the flow is. And if you wanted to write a little box above MCO, you could put in that box Department of Health. So if you're thinking about the flow of dollars for services, you would have dollars coming from the Department of Health at the top, running to a managed care organization, running down to an IPA, and from the IPA to individual providers. So again, think of an IPA as an intermediary organization. It is a very special kind of regulatory creature in New York, but in other states as well. And as we're going to get to, there are some things IPAs can do, and there are some things that they cannot do. We wanted to certainly underscore that as people think about accountable care organizations and disparate performing provider systems, those are organizations that look very much like IPAs, but they're not exactly the same thing. Okay, Dan, could you tell us if we still have sound?
Yes, indeed.
We do, okay, because we're seeing something in the chat that somebody lost sound. Okay, good.
That might be their own computer, so I'll send them a quick message. Thanks.
Okay, so again, ACOs, PPSs, IPAs, they all do similar things, but not exactly the same thing, nor is the regulatory treatment the same. So just a little bit again on IPAs right up front. What are some pros and cons about IPAs? So the first thing is that IPAs are very important for facilitating network development. Plans like to contract, health plans like to contract with IPAs because if an IPA has built up a network, in your case, let's think about a network of certain types of behavioral health providers, by signing with an IPA, they can at the same time bring into their network all of the providers who are part of that IPA. So the term that's often used is single signature authority. That's a kind of managed care term, but just think about the fact that by signing with an IPA, the plan with one signature gets lots of providers. So oftentimes plans welcome contracting with IPAs, but keep in mind that while IPAs can negotiate on behalf of all of the providers in the IPA, they're not unions and they're not guilds. There can be antitrust concerns that come into play with collective negotiation. And so as a consequence of that, IPAs are usually entities in the classic managed care model that share some risk. Now, we're going to talk a lot about risk agreements later on in this, but as we sit here today and as the HARP program starts out, we don't think that many of you are going to want to be considering risk arrangements. So you might say, well, can we use an IPA? Is there risk to it? Well, we still think IPAs are going to be a good structure here. And while there can be antitrust concerns, right in the beginning of this program, and as we're going to talk about, I think you know that most of the reimbursement rates are being set by the state. So, so I would say that IPAs are a useful contracting tool. Sometimes they make sense and sometimes they don't. And I would just point out that if you're a provider, you do not have to be part of an IPA in order to contract with a managed care organization. It's common for individual providers to say, I'm just going to do this on my own, and I'm going to sign an individual provider contract. But sometimes they want to be part of an IPA, and the two things are not mutually exclusive. Sometimes you can contract through an IPA, and sometimes you can contract independently, even with the same health plan. So lastly, I just point out that an IPA there is regulatory oversight. It's not a huge amount, but if you're creating one, you need a variety of sign-offs, and I'm sure everybody's looking at that and saying, why does the state education department get involved? Well, historically, that's because IPAs are an exception to the corporate practice of medicine prohibition, and so the state education department has a tiny little role in the approval of IPAs. Okay, management contracts, again, we're not going to spend a lot of time, but certainly I think in the behavioral health world, you may be familiar with management companies that help health plans manage these benefits. So think of Beacon or Value Option or Magellan. Management service companies can play a very important role in this. And we're going to talk in more detail about those later. And then there's another type of contract, which are administrative contracts. These are coming more into play. They sort of sit between a provider contract and a management contract. They're technically not subject to DOH review, but we've had types of services come up, the most obvious one being health homes, which you see there. Well, you know, people sort of struggled with this at the beginning. What is a health home? Is it a provider? Well, no, it's not really a provider. Well, is it a management service company? Well, it wasn't really that either. So health home contracts were treated as administrative contracts. And again, that sort of is a little bit of a cross between a management service contract and an unregulated contract. But these contracts are also very important for care management, and we'll come back and talk a little bit more. So provider contracts. These are the areas that we're going to walk you through, the key terms, the regulatory provisions, obligations that are imposed on managed care organizations, but that will affect you all as providers, compensation, which I'm sure people have some interest in, and the regulatory review process.
I think it's important to try and think about the contractual relationship as an agreement between two parties. This is really a partnership. You're setting up how you want to work together for some common goals. And so it's important for you to think about, well, yes, leverage is part of that negotiation process. It's important for you to think about how you can help the plan meet its regulatory obligations and what the plan can do for you in terms of meeting your regulatory obligations. This is not an intimidating or scary process that I've found or that I think plans see. There's a lot of regulation to it, so in some ways it's really about creating partnerships.
Right. So these are the key terms, and just again picking up what Whitney said, we know that at the start and as we go through these items, you may feel that it's adversarial, and sometimes it is adversarial, but really start out by thinking of it as a collaboration or a win-win, because a good contract will be a win-win. The reimbursement will be fair, the services will be clear, the obligations on both parties will be mutual, and so again, as you start out, and we're going to talk about this repeatedly, there are going to be some areas where you as a provider can bring a lot of value to the plan, not just through the services you provide, but through other things. So those are the key terms, and let's dive right into them. And let's start with something that may seem obvious, but it's not, and that's who are the parties to the contract. On the health plan side, that's usually pretty clear because it will be the managed care organization that is responsible for delivering the benefits to the Medicaid managed care members. But on your side, it's not so clear. First of all, the entity contracting, it's important that you pick, again, you may have several entities within your family of companies, maybe not, maybe you have just one. In that case, it's fairly easy, but you know, you may be part of an IPA, you may be part of a performing provider system, you can have providers with different corporate entities but under a common parent, and it's important that the right entity be identified in the contract. And that's going to flow right through through reimbursement, because ultimately you're going to have to give a TIN number to the plan, and that's going to be the sort of source within the processing of everything that gets you paid. So parties, you may be sitting there going, oh yeah, of course I know who I am. Of course I know who's signing the contract. But you would be surprised how often that becomes an issue because someone's identified the wrong party, or you have multiple parties within your corporate family and they're not all identified properly. Definitions are going to be a part of any provider contract and certainly any management service contract. I know they seem boring and they're legal, but obviously there's a lot embedded in those definitions, so you need to pay attention to them. The health plans certainly pay attention to them, and maybe the most obvious is the medical necessity definition.
Medical necessity is typically determined by the plan, and it's based on a common definition that is contained in the Medicaid model contract, which Harold referenced earlier, which is the contract between the plan and the Department of Health.
So, next key terms. Scope of services and access to services. So we already talked about the scope of services. Typically in the contract, you will see these in an appendix. That's because the health plan will have its own templates of contracts, and they may look similar as between a LICSA or a CHA or a Article 31 clinic or a behavioral health provider that's doing other than clinic services like HARP services now. So the model of the contract may be the same, but obviously the services are going to vary greatly from provider to provider. And so those you'll typically see in an appendix. And then the payment rate is going to be tied to those specific services. There are access to those services. Those are really important to the health department and to OMH. So what are the access standards? They're things like appointment available, and the plan is going to say to you as a provider, you're going to have to meet some access standards. Like, we want you open from 8 until 6 or 9 until 5 or whatever it might be. You may need to have some 24/7 backup. That's typically something that the plan wants to see. And you may say, well, what are those doing there? Well, that's because the health department says to the managed care organization, you have to provide a certain minimum level of access. So let's talk about payment adjustments next. What are those? Why are they there? Why do people care about them? Well, just think OMIG here, okay? Because there are times when a health plan is given by the state or by a local social service district, a Medicaid managed care enrollee, and they are covering that person, and then the state comes back later and says, oops, we made a mistake. You know, those services that, you know, the premium we paid you, we're taking it back. Well, when that happens, the managed care plan will say to the provider, guess what? You know, we paid you for some services, but we paid you for someone who we thought was our member. Maybe the state told us the person was our member, but they weren't our member. So we need to recoup that money. Everybody hates these, okay? The plans hate it, you hate it, and frankly, the state isn't a big fan of it, but they cannot reimburse the health plan on someone who shouldn't be a member. You know, obviously you see that sometimes where there are prisoners or dead people, but this comes up with Medicaid people who are out of state, but they look like they're in state. And there are many, many other examples where people are mistakenly enrolled. So, and there's, again, there's way more complicated examples of this too, which we didn't include, but this is an important provision. You need to understand it. You have some protection from some state rules about what you're supposed to be told. When there is a recoupment, the plan has to tell you why they're taking money back. You want to understand it, and you can push back. You may say, no, I don't, I don't agree with this. If you provided services, you still are going to expect to get paid for those services from somebody. And, it's important that you understand and that you begin a dialogue with the state that you can still bill those services on a fee-for-service basis. Because the fact that someone is in Medicaid managed care doesn't mean in some instances that they're not in Medicaid for other purposes or that you don't have the right to bill for the services you provided, because you understandably don't want to be providing services and not get paid for them. So that's an important provision to understand. Okay, administrative requirements. Not all of the things that the plan expects of you will be spelled out in the contract. Some of those are in other administrative contracts. Administrative requirements. They can make their way into contracts, but they won't always be there. But there will be a provision that says to you, well, we, the managed care organization, require you to follow our administrative requirements. What should you do when you see that? Well, ask to see them, okay? They're not state secrets. Typically, they will be made available so you can understand them before you sign the contract.
Most of the time they're available online now, and when changes are made or revisions are made to them, they're also available online. They'll notify you of those changes.
Right, and let me give a very important example here, which is timely filing of claims. So I know people often think that health plans want to take your claim and sit on the money and not pay you, but actually that's not true. That most times they actually want to get their claims paid timely, even to the point, and there are lots of reasons for that in terms of getting an accurate claims data and understanding the liabilities on their books, but it's very common that health plans will tell you, you must submit claims to me within a certain time period. And for Medicaid, that's often 90 days. If you wait and it's the 91st day and you're submitting a claim, that claim can get rejected. Now, there are some other state rules around this, but it's very important both for your business but also for your compliance with the contract requirements that you be able to submit those claims in a timely fashion. And you won't necessarily see that in a contract. You may see that in the administrative requirements. So let's talk about insurance. Again, that's kind of a boring topic, but it's really important. Health plans do not want to contract with providers who don't have malpractice insurance and general liability insurance. That was a huge challenge when the personal care services were brought into managed care, because many of the smaller personal care providers did not have their own insurance, and they were getting it, especially in New York City, through a special New York City program. I'm guessing most of you have it, but if you don't have insurance, you need to be thinking about that now, because most health plans will not contract if you don't maintain a certain level of insurance for malpractice and for general liability insurance. Why is that important? Well, look at the next issue, indemnification. Health plans don't want to be sued for your errors, and frankly, you don't want to be sued for the health plan's mistakes. You will see in almost every managed care contract an indemnification provision. It's fine to seek mutuality in that. So when we say mutuality, that's kind of a legal term, but it means, said differently, what's good for the goose is good for the gander. If the plan wants you as a provider to indemnify them for your negligence or other problems, by the same token, if you get sued for something that they did wrong, you should get indemnified. So again, don't be afraid to ask for mutuality. It's fairly common to see it with indemnification. Now, of course, if you have insurance and they have insurance, it's less likely that either of you will have to worry too much about those issues. So that's, again, why insurance is really important and why the plan wants to require you as providers to carry insurance. The next provision, I'm sure you've all seen these, but if you haven't seen these provisions, you're going to see them in every single contract. There will be a requirement that you, and you may require it of them, comply with all applicable state and federal laws and with the Medicaid model contract. So HIPAA, anti-kickback laws, general Medicaid and Medicare laws, but again, you'll see these in a very broad-based way. The state will require it. OMIG wants to see it. So again, they just want to know that you're complying with laws, and I assume that providers typically want to see that from the plan and ask for it as well. Term and termination. So what does this clause mean? What does this item mean? It's really a question of how long does the contract run and what happens if either party wants to end it earlier, okay? This is, again, not like fee-for-service. You don't have a lifetime agreement unless you get thrown out of the program. Most of these contracts will have a date on which the contract ends. Hang on. You may say, why is that? You know, why does the plan want to see that? Well, because if the contract ends on a date, you know, typically they run annually, so you'll see them, you know, January through December. They can be for more than 1 year. But at the end of that contract, if you don't want to continue or the plan doesn't want to continue with you, you're both done. There are no more rights. There are no due process rights that you're entitled to and no due process rights that the health plan is entitled to other than some continuity of care requirements. Now, if either side wants to end it early, that's when you get into what we call for-cause or without-cause terminations. Let's say the health plan isn't paying you in a timely way, and you're tired of providing services for not getting paid. Well, you know, it's a very obvious example of why a provider may want to get out. By the same token, let's say the plan is concerned that there are quality problems from a provider or there's an access issue, you're not giving appointment availability when you're supposed to, they will say, we're not continuing and we're going to terminate if you end up on the OPMC website because there's been some sanction that Medicaid or some other entity has taken. The plan must terminate you. The state will not allow the plan to keep in a sanctioned provider in its network. So that's an idea that it's a very, very important provision for both sides. And again, it tends to be mutual.
I would just add that most contracts, typically you'll find, will have what we call an evergreen clause. So they may be for a year, an annual contract, or they run for a year, and they will automatically renew unless somebody, you know, affirmatively says they do not want to renew. The other thing that is important to consider is the length of time for notice in the event you want to terminate or you want to non-renew the contract. There is some state requirements as to how long that period of time can be, but typically the plans will say 60 days or 90 days, although those terms are oftentimes subject to negotiation.
So next topic, representations and warranties. Again, this is a legal sounding thing. You may not see these in other kinds of contracts, but you will see them here. The health plan wants to know when it enters the contract that you, if you're a licensed entity, that you're properly licensed. You know, they're typically going to ask for a representation maybe that you haven't been suspended or terminated, that you're not under some major investigation that you haven't told them about, that you have the capability to do what you need to do, that you've got corporate authority to enter into the contract, and again, you're going to have some representations that you want from the health plan. So let's talk about amendment to contracts, and we did get some questions about this from people who were at some of the earlier presentations. So you can always amend a contract if both parties agree, okay? So even if you enter into it, things change, and so the fact that you signed it doesn't mean that you can't come back and say, hey, this is different. You know, obviously payment terms will change, but sometimes there are other things that change. And there can be performance standards, quality issues. So yes, even if it's a 2-year contract, you can always come back to the table. There are times when the health plan will say, we are keeping the right to change this unilaterally, but we will give you 30 days notice. And if you don't raise your hand on within that 30 days, then it's a part of the contract. A common example of that are changes due to regulatory requirements. A benefit gets added. There's a change to processing payments.
Standard clauses, which I'll talk about later, but every few years the state will come out with new standard clauses that have to get attached to the contract,
right.
And you don't want to have to go around and get signature authority for everybody in your network just to change the contract requirements that the state is imposing on you.
So again, you know, if you get such an amendment, pay attention to it, because if you have one of these 30 days provisions in your contracts and you don't raise your hand, within those 30 days it's going to become binding. Next, assignment. It again sounds really legalistic, but it's very important to the health plan. And that's that there are times when the health plan wants to assign your contract. You most typically see that when a health plan is being sold, and the state wants the network to migrate from the seller to the buyer. You will see assignment provisions that may say we can assign your contract without consent. That may be fine to you. You may want to be assigned in many cases. Sometimes it's assigned on notice and you have the right to agree to it. But again, it's going to look to you like a bunch of, you know, it may look like it's legal boilerplate terms, but again, there's a very important business reason why it's in there. Okay, there are notice requirements. Again, these are mostly if something bad happens to you, or conversely, if something happens to them. But certainly when you see these provisions, they are largely a function of OMIG requirements, and that's what they're doing in there. Dispute resolution. You can do almost anything you want for dispute resolution. We think that alternative resolution, meaning that there's an arbitration type of resolution when you have a dispute, is good. It's good often for both sides because it's less costly than going to court. It's more timely, and we tend to think that they're good for both sides. There are lots of examples of dispute resolution entities. AAA, the American Health Lawyers Association has a service. You can agree up front that you want to use somebody. You can just agree that it's a mutually acceptable entity. Again, you don't have to do it, but we tend to think that for many of these contract disputes, that they are more easily and more quickly resolved through a dispute resolution process rather than having to go to court.
Oftentimes you can create an internal dispute resolution process that's between the plan and the provider, so you're identifying you know, what the process is going to be, that you're going to try and work out the dispute internally before you go to some kind of outside entity.
Okay, last bullet on here is just that there's a right to monitor and audit. It's the provider, again, they have to have some ability to do that because it's part of both member satisfaction issues, quality assurance issues. So the managed care organization is going to require that there be certain kinds of oversight rights. So let's go to some regulatory provisions, and I'm going to hand it off in a minute to Whitney. So we talked a little bit about the DOH provider contract guidelines and some standard clauses. We're going to walk you through what those are. These are things you will see in the contract, but they're coming not from the managed care plan, but from the state.
Right, so as Harold said, I'm going to talk about the regulatory provisions that are imposed upon the plan that it imposes on the providers. So there's a very useful document that you can find online at the Department of Health website called the New York State Department of Health Provider Contract Guidelines. It sets forth the rules, really, that plans must follow in their contractual relationship with providers. The guidelines talk about some of the mandatory provisions that must be in all contracts. Those are referred to as the standard clauses, and I'll talk about those in a little bit. They also identify some of the minimum statutory requirements that plans must follow. They aren't necessarily in the contract, but they are things that the plans have to adhere to, like prompt pay law and things like that. They also set forth the rules for how the Department of Health is going to oversee and monitor the plan's contract. So as Harold kind of referenced before, most of the time, most plans have what we call a template contract, which is their standard agreement that they have with a particular provider that they have submitted to the department, and they've said they've gotten approval from the department that this contract complies with all the state laws and regulations. That contract is then the basis for which negotiation begins with a provider. As we just went through, some of these provisions can be negotiated, and it is a back and forth, it is a partnership. When changes are made to that contract, those changes, the Department of Health must be notified of those changes. Sometimes those changes can just be made and the contract can be filed and automatically used. If, however, substantial material changes are made to that contract, then the contract has to go back to the Department of Health. It sits for 30 days and has to be approved. Each contract has to contain the standard clauses. They have to be specifically attached and incorporated into the contract. They do control in the event of any inconsistency or conflict with whatever's in the base agreement. So the standard clauses are what has to be adhered to. Some of the standard clauses that are kind of relevant or important for you to know about is the no balance billing of consumers. So providers are precluded from billing consumers for services that are not covered by the plan. They have to hold the provider harmless, to hold the member harmless. And the plan is really ultimately responsible for making sure that the providers aren't billing enrollees unnecessarily. It's also important to note that if the provider wants to render a service that is not a covered service under the benefit plan, the provider must put that in writing and get sign-off from the enrollee before they render those services. The standard clauses have the continuity of care provisions, which basically say that the provider must continue to provide care must provide care until a medically appropriate discharge or transfer or completion of a course of treatment. The member has the option to continue services with a provider that leaves the network for up to 90 days, but the provider and plan have to agree on to continue the rates under the agreement for that period of time. There are certain term and termination provisions in the standard clauses. For instance, an institutional provider cannot be terminated on less than 45 days notice unless the plan can show to the Department of Health that there's imminent harm to patient services. The standard clauses also set forth the requirements for getting consent for being able to share information back and forth between the provider and the plan, which is important for purposes of, sharing data, medical records, especially when it comes to substance abuse, mental health records. There's specific state rules on that. In addition to the standard clauses, many of the issues that historically have caused kind of provider plan angst has dissipated as various consumer and provider protections have been legislated. So we now have statutory provisions that plans adhere to. It's important for you to know that those are minimum requirements that the plans have to adhere to, and that the providers can, in some instances, can ask for provisions that are more protective of the provider. Again, though, you can't contract around the statutory provisions. So it's like the prompt pay law. The prompt pay law says that plans have to pay providers, ask for more information on a claim within 30 days, or pay the provider within 30 days if it's an electronic claim, or 45 days if it's a paper claim. Plans can't contract around that. They have to pay within those time frames. Interest is imposed on the plan, and so frankly, plans get penalized both with interest and with also annual fees from the Department of Financial Services. So there's no interest in the plan for not paying timely. Some of the other statutory provisions that you want to be aware of is their provisional credentialing rules. Plans have to credential providers within 90 days. Certain providers will be deemed credentialed, so if a new provider joins your network or joins your group, that new provider will be included as part of the group for purposes of payment for a period of time until the plan can get around to credentialing that particular provider. The rules about appeals for medical necessity, those are all in Article 49 of the Public Health Law, and that gives both the providers and the enrollees rights to appeal medical necessity determinations. Typically, there's an internal appeals process with the plan, and then the plan and the provider oftentimes have the right to be able to go to an external appeal and get an independent review determination if need be. As Harold suggested, there are claim submission deadlines, 90 days typically for Medicaid plans and 120 days for commercial plans, and there's also rules about how overpayments have to be handled. Plans have to notify providers before they recoup any payments. They can't just automatically come in an offset based on future payments that will be made, but they have to notify them if they're going to be making adjustments to a payment. In addition to the provider standard clauses and the statutory requirements, what we have talked about, the Medicaid managed care model contract has specific requirements that are imposed on the plans. The model contract also can be found online, and every plan has the same contract. So there's nothing new. There are no nuances that you need to be aware of.
And let me add on that, it's really long, but it's definitely worth reading, okay? Not before bed, but again, it's hundreds of pages, but if you really want to understand how this program operates, go to that website, go look at the contract. There's going to be a new one coming out fairly soon because we're working on finalizing the latest version of it. But again, unlike other places where you might go to statutes or regulations, you won't find very much of that here, but if you go to that managed care contract between the state and the MCO, you will find the whole structure of the program laid out for you.
It will set forth, all right, we'll go for it. HARP, there is an RFQ, which is another document that you might want to be aware of for purposes of HARP. We don't have a HARP model contract yet. So some of the provisions in that model contract that you want to be aware of. Plans have an obligation to provide an adequate network, which means they have to provide a full array of mental health and chemical dependency service providers in sufficient numbers to ensure that their enrollees have adequate access. These providers can be individual practitioners. They can be licensed by OMH or OASIS. And it's important to know that New York is not an any willing provider state. So, so that if a provider wants to be in someone's network, the plan has the choice to say that they don't want that provider in the network. And this is very important from the plan's perspective because they want to ensure that they have quality providers in their network. So if there are reasons why they may say that they don't want somebody in your network or they don't want a particular type of provider in their network. Let's say, for instance, they don't think that that's safe for their enrollees. Access standards and requirements can be found in the Medicaid model contract. Plans must ensure that their providers are providing an urgent care appointment within 24 hours of a request. Follow-up after an emergency or inpatient admission must be made within 5 days of a request. A non-urgent mental health or substance abuse visit must be within 2 weeks of a request. If somebody wants an assessment with respect to their mental health or substance abuse services that they may need, that needs to be done within 10 days of a request. In some situations, providers must be reimbursed for medical language interpreter services. Typically, providers must have somebody that can provide a benefit under the package within 30 minutes or 30 miles of an enrollee's residence. All providers are listed in a provider directory. There's an obligation that they have specifically a provider directory for mental health and chemical dependency service providers, and that they identify which ones can actually provide services to children.
So let me jump in on the provider directory for a minute, because this is a perfect example of where a requirement that the state is imposing can turn into a big win-win or a big lose-lose for you and for the managed care plan. Both the health department and sometimes the Attorney General's office will make calls, sort of secret shopper calls, to providers who are listed in the directory, and if that provider says they're not in the network, but the managed care plan is showing them as being in the network, then the managed care plan has to do corrective action plans. They can be fined. There are very significant sanctions for that. Knowing what plans you participate with and accurately answering those questions is a huge benefit to the managed care organization. And if you answer it wrongly, they're going to come out. There's going to need to be training. There's going to be a whole range of other remedial action. And, you know, providers who answer correctly get gold stars, so both for yourselves and for the plan. So, again, that's just an example of where doing something that's pretty basic, which is answering a secret shopper call accurately as to the plans with whom you participate, can have, you know, big consequences up or down.
So plans have to submit encounter data to the Department of Health twice a month. The new model contract proposed that's coming out, there's actually a $2,000 per day fine imposed on the plans if that information is not submitted. So it's critically important that the providers be able to provide that encounter data to the plans. You'll sometimes see in contracts where the plans impose financial penalties on providers if they're not submitting this encounter data, and that's the reason for it. MCOs must also operate a quality assurance program, and there is a quality assurance reporting requirements, which is a document which is publicly available and also on the Department of Health website. It's important to know kind of the plans you're contracting with, how they fare, and how do they perform based on those core measures. Think about how you can help them satisfy those measures. There's specific mental health and substance abuse measures they're in the Medicaid contract, and there are also proposed measures in the HARP RFQ. And so it's important to think about how you can think about helping those meet those measures. I'm going to skip that. Compensation.
So let's go to something I know everybody cares about, which is compensation. There are different types of compensation. The most basic, which is probably what you're almost used to, is what we call non-risk, which is simple fee-for-service. You, as a provider, provide a service. You get paid for that service. I think the good news is as we start the HARP program out and as behavioral health services are carved into managed care, the state has said that basically unless the parties agree to something else, that the providers are paid will be paid at the same Medicaid rates that for the first 2 years of the program that you've been getting. Okay, you know, that's easy. But at the same time that the state is protecting the fee-for-service rates as this program starts out, there is a major, major policy push at all levels, and those of you who are involved in DSRIP know this. There's a major push from the state and from CMS to go to value-based arrangements. So what is a value-based arrangement? It's a way of paying that is not just looking at whether the provider provided a service and you got paid for that service, whether it was a good service or a bad service or a useful service, and looking to develop reimbursement methodologies that are looking more at outcomes. The most obvious kind of way to do that is to have a risk agreement, and on the next slide we're going to talk about risk arrangements, but there are other kinds of value-based arrangements. The most obvious is payment for quality. If you get your, no, go back just for a minute. If you provide—
Hey, Harold and Whitney? Sorry to interrupt, and we're getting a few messages about the slide deck not moving. So just for folks who are listening in, we're doing what we can to get the slide deck synced up to where Harold and Whitney are. So just bear with us.
Okay. Well, we're on slide 24 for those who are following it.
Well, it's 32.
All of GT just lost the web. That's why it's not forwarded.
Oh my God.
Yeah. So hopefully it's coming right back up.
Okay. The problems at our end, guys?
Perfect.
Dan,
no,
we just got it now. It over. Okay.
Okay. So everybody, we're on slide 24.
No, it's 32, Harold. This doesn't include Dan's slides.
Oh, okay. Sorry, we're on slide 32 of Dan with your slides. But it's the slide that says value-based arrangements. So again, the most obvious kind of a value-based arrangement that doesn't involve risk is payment for quality. You know, plans may well be willing to pay you for even some basic quality things like getting your encounters in, you know, reporting on data. Those are easy things to do. And then those arrangements can evolve over time to some of the more complicated risk arrangements that we're going to talk about.
Right. Another good quality measure that you could think about that's somewhat of a process measure is, you know, has the provider met with the enrollee within 5 days after an inpatient admission?
Right.
Right. You could get extra points, you know, potentially extra money for that if you can help them meet that quality measure.
Right. So again, reducing unnecessary readmissions, I think most of you know, is a huge goal of the state, DOH, OMH, CMS, and there's a lot of pressure on the plans to work with its providers to make that happen. So to Whitney's point, if you're able to see those patients in the required time frame, yes, maybe there's an additional payment that goes to you for meeting those requirements. Okay, Dan, did the page move forward?
Nope, but I just moved it for you guys.
Okay.
Thank you.
So it's page 33. Okay, so on our slides, it's slide 25. Okay, so these are types of risk arrangements. There are all different kinds. There's what we call a capitation payment, where a lump sum is paid maybe on a monthly basis to a provider, and for that lump sum, the provider has to provide all of the services that are in that contract. You have things called bundled payments, again, shared savings. That's going to be, I think, a big area. We just talked about it, where there are bonuses or upside benefits, amounts that are paid for good performance, but there's no penalty for the downside performance. Those things will be good, again, as you start out in a managed care world to think about, but over time, the state is going to be pushing everybody. They're certainly pushing the health plans, but they're going to be pushing the providers, and obviously you see this with DSRIP and PPS, to move not only away from fee-for-service and away from upside bonus only, but into truly aligning the interests of both the provider and the health plan to provide quality services within defined kinds of budgets to both improve quality and, frankly, control costs. So,
yeah, there's actually a directive in the Medicaid contract that requires each plan to increase each year by a certain percentage the total number of providers that it moves away from fee-for-service to value-based purchasing.
Yep, and it's also part of, for those who are following FIDA, it's a requirement in the CMS terms and conditions that the state move over a 5-year period to value-based purchasing. So this is, you're going to hear more and more of it. Again, I think for the first 2 years, we won't necessarily see a lot of it, but some of you may want to do that. And the plans are, you know, perfectly willing to engage in those discussions, and you should be thinking creatively, especially at the beginning, about where can you add value and how do you get reimbursed, even if only on an upside basis, for good performance.
Well, it would be a very good idea for in the next 2 years to get a good sense of your data and how much it costs you to provide your services, so that when the 2 years comes up, you're ready to start to move into some kind of value-based payment arrangement. So the next slide really talks about the reviewing of the financial arrangements between the plans and the providers that the Department of Financial Services and the Department of Health review. DFS reviews all prepaid capitation, so any PMPM payment, any monthly payment per member that is made, regardless of the amount or level of services that are rendered to that member. DFS reviews those, called Reg 164. The Department of Health has, you'll see in the provider contract guidelines, they've created 5 specific risk level categories. Depending on the level of risk assumed by the provider determines the level of financial scrutiny and oversight of the provider. As you may or may not be aware, plans have huge financial reserves that they need to have in order to be a plan, and that's to ensure that providers get paid in the event that the plan goes bankrupt. And as providers start to take on medical risk, the Department of Financial Services and the Department of Health wants to make sure that those providers have the financial wherewithal to be able to assume the level of risk being taken on. And so the Department of Financial Services basically says if you're getting paid $1 million over a 12-month period in a capitation payments, then the Department of Financial Services wants to see 12-month financial projections, certified financial statements. They want some kind of financial security deposit, and they have the right to be able to audit the provider's books and records. So Harold's going to speak now about when it is good to kind of contemplate a risk-sharing arrangement.
Right.
What you want to think about.
And Dan, you just moved it, right?
Yeah, and just so you guys know, if in the background, it sounds like you guys are still connected by phone, but your computer connection might be out. If you want to try on whatever computer it is to rejoin, we can make you presenter again.
Yeah, we're having an Albany-based issue with the internet, so why don't we just keep going here?
Yeah, that sounds great. Just keep saying next slide, and I'll keep flipping through.
Yeah, okay. So we're on the slide when to contemplate a risk arrangement. And again, this isn't necessarily a short-term front-burner issue for you, but as Whitney said, understanding your data is critical. You should not go into a risk arrangement unless you understand your own performance, and if you're in some sort of group dynamic with an IPA or an ACO or a PPS, you need to understand what that looks like. Obviously, managing utilization is important. This is about providing the right level of care at the right time, but not providing necessarily, all aspects of care all the time. So, right care, right time, right place. If there's a risk arrangement, again, it should be mutual. We talked about starting with upside risk, but then, over time, the managed care organization is going to want to move to a risk-reward type of system. And then, again, control over the services in which you're assuming risk. You have to know that you can control what you're doing as an individual provider, but if you're going at risk for not just your own services but others, that can be, that's sort of the highest level of risk. And again, we would encourage you to be very, very cautious about doing something like that. So let's sort of just quickly kind of wrap up and go to some questions. Go to the next slide, Dan.
You can't see it because we don't have the web, so you have to assume we did.
Dan?
We're not on the web, so you can't see it.
Hey guys, which slide would you like me on?
The slide that says other things to know and consider.
Perfect, got it.
Okay. So again, this is just a quick slide to really understand the marketplace, understand what your managed care contracting entity wants to do, what you want to do, who the competitors are. Again, you know, strengths and opportunities. We talked a lot about things you can bring to the table, the quality of your services, your responsiveness, you know, even your appointment availability. Those are really important business issues for you to consider, and if the plan sees that, you know, you're bringing some value to the table beyond just the I can provide this service on this day, this counseling session, or this peer session or whatever, if they see that you're striving hard on a consumer satisfaction basis, you know, that gives you some ability to say, I want either more money or some other concessions that are important to you. So next slide, Dan.
So quickly, I just want to talk about the IPA contract, and it's important for you to know that there are two contracts involved when there's a contract with a plan and an IPA. So there's the contract between the IPA and what we call the downstream entity, or you as the providers, the participating providers, and that's going to contain a lot of the same provisions that we've already talked about in the other provider agreement. And then there's the contract between the plan and the IPA, and that to some extent can be a little bit different. It could delegate credentialing. It's typically where the risk-sharing arrangement would be contained. You want to kind of work through who's paying claims. Is the plan paying claims, or is the IPA paying claims? There's certain rules as to whether or not there's discretionary authority with respect to the claim and whether or not an adjuster's license is needed for purposes of paying claims. But those are all things that need to be considered at some point when you're entering into an IPA contract.
Dan, just given timing, I'm not sure we can see the chat, but if there are lots of questions, rather than go into management contracts, I think we maybe like to take the questions, but we can't see them, so maybe you can read them if there are a lot.
Yeah, I'd be happy to. So let's start off something around home and community-based services. So just a question about if you guys could elaborate a little bit more on HCBS and any special considerations, any advice for contracting with MCOs and handling billing requirements.
Right, so obviously home and community-based services is a major area of services that have been brought into managed care for certainly through the Managed Long-Term Care Program and also through FIDA. There is nothing special about them in terms of the contracting issues. I think it's the same issues, but again, from a quality perspective and an accountability perspective, it's important. There's a lot of scrutiny over those services. I think people know from OMIG, health plans are being audited right now by OMIG on provision of home and community-based services. Did people receive, the patient, the member receive what they were supposed to receive, things like hours. So I would say as a general matter, you know, it's going to be the same sort of a contract template, but there are going to be some unique features of those services that, in terms of performance requirements, that plans may be focused on.
Right, I think it's important that the providers capture and document the services. That's going to be a key factor for them. It's also, the plan is going to be, is going to have to ensure, I assume, that those are also services are being provided in the home and community-based setting, which is another big issue for some of the facilities right now.
Yeah.
Next question.
Great. Yeah. How about from you guys' perspective, the plan receptivity to negotiation of contracts and specifically mutuality?
Right. So again, I think there's a view that, you know, you're handed this model contract and you're told take it or leave it. And certainly the MCO is going to start with its own template agreement for the type of service, but these are negotiable. We received a question, I think from one of the earlier sessions, do you need a lawyer? Well, probably if you want to negotiate a lot of the provisions, you may want a lawyer. It's probably good at some point. But you don't always need a lawyer, and frankly, the plans often don't use lawyers. They have provider contract teams of non-lawyers who are out there working on this. Some provisions are definitely negotiable. Term and termination, for example, is negotiable. Assignment can be negotiable. Other things, compliance with laws, that's not going to be negotiable, okay? If you're not willing to agree to a provision that you comply with all laws, you are not going to get a contract. Again, I would certainly encourage you to focus on the things that are important to you from a business perspective. Some of those you're not even going to see in the main contract. They're going to be in appendices that may say things like performance standards, and those are definitely negotiable.
Great.
Next question.
So I think this one came in just when you lost computer access. Do IPAs, going back to the beginning of the slide deck, do IPAs which involve OASAS or OMH certified providers that include those services also require approval by those agencies?
Yes. The formation of the IPA does require the approval of, it's a sort of check the box approval from State Ed and the Department of Financial Services. It's a little bit more, but not a lot more from the Health Department, but the Health Department has the oversight authority of IPAs no matter what type of providers they are. So in terms of the agencies we put up, even if it's behavioral health providers, the formation of the IPA, which is not active oversight, it's just the corporate establishment, does require the sign-off, even if it's behavioral health providers.
The Department of Health has a very good website about how to form an IPA and what information you actually have to provide to the Department of Health when you're wanting to form the IPA. And that can be a useful resource.
Great. So moving on to the next question. Do you know if FIDA providers who are contracting with managed care are mandated to receive Medicaid rates? Or can MCOs come up with their own rates?
Own rates.
Yeah, there's no mandatory rates for FIDA.
Great. Another question about HCBS has come through. We are a supportive housing nonprofit. Hello and welcome to the webinar. Can we contract with MCOs to provide home and community-based services only for the individuals who live in the buildings we serve, or will contracts require us to serve anyone the MCO refers to us?
It will, well, okay, so that's a really good question, and I want to try to break it apart, not having it in front of me. So if you have members in your supportive housing program who are members of the MCO and you have the contract, then yes, you would obviously be required to serve those members. If you are sent a member by an MCO, you're not necessarily required by the contract certainly to accept that member. You may not have room, there may be constraints, it may be someone who you don't think is appropriate for your supportive housing program. So just as with any provider, just because you're in their network and you have a contract, it doesn't mean that you have an obligation to serve everybody who is sent to you under all circumstances. I mean, on the other hand, what you can't do is engage in cherry picking or sort of a process that would look like discrimination where you're taking easier to serve people but not harder to serve people. So, you know, you can't sit there and necessarily pick and choose, but if you've got
Harold, are you guys still with us? Folks, it sounds like we lost the audio for Harold and Whitney. We're going to give them just a minute to reconnect. It sounded like there were some phone and internet problems up in Albany. So just sit tight and we'll resume the Q&A in just a minute. And folks, while we're waiting for Harold and Whitney to rejoin us for just a few more minutes of Q&A, please feel free to continue submitting questions. And what we're not able to get to on the call today, we'll be sure to add to our contracting FAQ that'll be going around in January. And as folks may have seen, a link just popped up in the chat box while we're waiting for Harold and Whitney to possibly rejoin for a feedback survey, which obviously for the tech side of things was obvious for today. But if you could give us some feedback on some of the content and slides that they ran through, we'd really appreciate it. And then, like we mentioned before, we'll be putting a recording of the presentation itself and the slides on mcjack.org in the coming days. Hi, everyone. Sorry again for the tech problems on this end. It looks like we are just going to wrap things up at this point. And if you do have other questions or if we didn't get to your question, please feel free to send us an email at mctac.info@nyu.edu. and we'll do our best to get back to you as soon as we can. Thanks so much for coming today. Hope the information and presentation was helpful, and a special thanks to Harold and Whitney for bearing through some technical difficulties and providing some great information. Thanks, everyone, and hope to see you in January at our in-person contracting forum in New York City.